be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to those of you joining us this evening during our Lung Cancer Living Room. For those of you who may not know, I'm Danielle Hicks. I am Chief Patient Officer here at the GO2 Foundation for Lung Cancer. I think many of you are familiar with this programming, but if you're not, it's a support and education series that we created specifically with patients and caregivers in mind, with the goal really of bringing to you live and in real time educational talks from key opinion leaders in the lung cancer community, and really in a format and a language that's easy for you to understand. Tonight, as you may have seen, we're going to be talking about pathology and understanding the role that the pathologist has in not only diagnosing lung cancer, but the process to staging lung cancer, biomarker testing, and even treatment options. The pathologist really is, in my opinion, the behind-the-scenes unsung hero who most of you never get to meet, but they work tirelessly with your care team to determine the precision, type, and severity or the stage of your cancer. They may also work with other members of your care team to recommend a treatment strategy that could include observation, surgery, chemotherapy, radiation therapy, targeted therapy, immunotherapy, or a combination of these approaches. So we are pleased to introduce to you tonight Dr. Maureen Zakowski, who is the professor of pathology at the Icahn School of Medicine at Mount Sinai Medical Center in New York. She's the chief of Cytopathology and a thoracic pathologist. So welcome, Maureen. So if and when a tumor is found in the lung, what is your job?
Well, the tumor is not found in the lung until we say so. So what happens is a patient gets a study, an X-ray, a CT, perhaps because they have symptoms or perhaps because they want to be screened. The X-ray can't tell you what that is. It can give you a list of possibilities, but it can't name it. So we are the ones who decide if it's a tumor or not. If it's a tumor in the lung, our first decision tree is it lung or did it come from someplace else and land in the lung? And that can actually be kind of difficult because the majority of lesions in the lung are metastases from somewhere else, which people don't often realize. So we have to decide if it's a tumor, if it's a malignant tumor or a benign tumor, because they both exist, if it started in the lung or if it traveled from the liver to the lung. Now, once we do that, and let's say we've narrowed it down to a lung primary, then we try to decide what kind of a primary is it. Is it adenocarcinoma? Is it squamous cell carcinoma? Is it small cell carcinoma? Is it something much more unusual? The most common primary lung tumor is adenocarcinoma in this country. That's not true for all countries. And once we determine what kind of a tumor it is, then we begin a whole series of studies to extract from that tumor information about it. Pathology is the study of disease, and our job is to get information out of human tissue. Long time ago, when I was a young doctor, we only had two kinds of lung cancer, small cell and non-small cell, because there were only two kinds of treatment. And that's changed drastically in the past decade. So let's say, for instance, I have an adenocarcinoma. I want to know how big it is. I want to know how poorly differentiated it is or how well differentiated it is. I want to know if it's making a substance such as mucin. I want to know if it's indeed, can I prove it's from the lung? I want to send it for molecular studies, for studies that, for example, PD-L1, which is a marker of possible response to therapy. Now, when I say send it, some of those things I do myself, and some of those things are done in a molecular lab. So a piece of viable, good quality tumor, meaning the cells are not dead. And we can tell what the cells are dead or alive by looking at the microscope. We want a good piece of live tumor, and we send it to a molecular lab so that it's thoroughly investigated for abnormalities in the genetic structure of the tumor. Once we find out what those mutations are, we can learn an awful lot about the tumor. We can tell by looking at that pattern of mutations whether someone smokes or doesn't smoke. We can tell by looking at that pattern of mutations if we think it's an adeno and we've made a mistake and it's a squamous cell. A lot of this information comes from the mutational profile, but the most important thing that comes is it tells us what treatment the patient will most likely respond to. And with that information, we pass that on to the oncologist or the surgeon. And in a sense, by identifying those abnormalities, we are directing the choice of chemo. And that's extremely new for pathology. That's something pathology never did before.
Before we jump into the biomarker testing piece and the treatment piece, you mentioned a couple of things that I'd like to better clarify for our community. And you talked about poorly or well differentiated. Can you explain what you mean when you say that?
To some degree, cancers look like the organ in which they're found. So if you have a primary tumor of your liver, it resembles liver. If you have a primary tumor of your lung, it can resemble normal lung tissue. And in fact, there are some lung tumors that so closely resemble normal lung tissue that it's difficult to see if they're even tumors. If a tumor closely resembles the organ in which it began, it's well differentiated. And the less it looks like its original self, if you will, the more poorly differentiated it is. Now, sometimes that makes a difference and sometimes it doesn't. Poorly differentiated is usually associated with more aggressive behavior, but not always. But it does give us some information about how the patient's tumor should be approached, how the patient's total being should be approached, and it also helps us if the patient gets another tumor. So let's say a person has a very poorly differentiated lung tumor, and 2 years later they get another tumor, and it's extremely well differentiated. It's not the same tumor. So that gives us a lot of information. We can tell by looking at the tumor if it's lung or if it's brain. That's another thing that we do. But certain tumors go to certain places, so we know where to look. It's not uncommon for lung cancer to first present in the brain. In fact, you could have a seizure and be worked up and be found to have a lung tumor metastatic to the brain. Bone, liver, even skin. And that is not skin cancer or bone cancer or liver cancer. It doesn't mean you have developed another cancer. It means the tumor that you had broke up and traveled and landed someplace. And we're not going to decide whether it's better or worse to have a met or new primary. It depends on the type of tumor. But it's not, remember what I said earlier? The mutation's not in all of your body. It's just in the tumor. So the mutation's not in your brain. It's in the tumor that went to your brain.
What role do you play in staging, and how does a pathologist like you determine the stage of a lung cancer?
The stage of a lung cancer means how far it has spread and or how big it is. There's two kinds of staging. There's clinical staging and there's pathologic staging. Clinical staging is when you look at a patient, examine the patient, look at the patient's result, look at the patient's scans and say, okay, I think this tumor is this big and I think it's located here. I think it's located there. I think it's stage X. Pathologic staging is when we take the tissue, look at it, and measure it, and say where it is. And usually pathologic staging upstages clinical staging. So for example, you look at someone's x-ray and you see something in the lung, and you say, oh, it's a small lesion, it's a stage 1. I'm going to check the lymph nodes routinely. Sometimes it's called EBIS, sometimes it's called mediastinoscopy. I'm going to check those lymph nodes. They look small, they don't look like anything on the scan, but we're going to check them. And they give them to me, and I say, you have tumor here. That's an automatic upstage, but it can't be seen on the x-ray, and clinically, the patient may be stage X, but when you put the pathology information in, it can become stage Y. So you could measure a tumor on an x-ray at 2 centimeters, but if you give it to me, I can say, sorry, it's 2.5, or I can say it's only 1.5. So there's a difference. Generally speaking, pathology stage upstages, because we can see things with a microscope that you can't see without it.
I think that's really important. I think it's important for a lot of folks, again, that we talk to who were originally clinically staged at maybe a 1 or 2, and then they go in for surgery, and their surgeon does pull these nodes up the chain, right, and send them to you, so you can say yes or no that we found cancer cells within.
Exactly. Now, sometimes they do that during the surgery. Sometimes they do it before the surgery. Sometimes they do it in a separate surgery. And very often they do it with cytology. Now, cytology is different than surgery. Surgery is where they go and they remove a piece of tissue. Cytology is where we stick a needle into something and pull out a few cells. Or we look at fluid, like fluid that might collect around your lung or fluid that might collect in your abdomen. We look at that with the microscope, and we don't have pieces of tissues. We have individual cells.
You mentioned EBS, and I know there's navigational bronchoscopy and some of these this newer technology, but historically and still, you're talking about you're not going into a liver or into a piece of bone. You're going into a very active, right, organ in your body to try and pinpoint this tumor, and not just pinpoint the tumor, but the center of the tumor, to be able to pull out enough adequate tissue for you to be able to look at. So on that subject, I think quite often, I think patients have called us historically and said, well, I'm really discouraged because I went in for this biopsy and it went off to pathology, but there was either not enough tissue or it was what they call necrotic tissue. Can you explain what some of the challenges are around accessing good quality tissue and what good quality tissue looks like, up to and including if someone has multiple lesions? Sorry, this is a sort of a 3-part question, but if someone has multiple lesions, do you need to pull tissue from each lesion? Are they the same? Are they different? What does good look like in that?
Okay, well, there's a lot of things here, so let's just unpack it a little bit. Okay. When you do cytology, an interventional radiologist takes a long, thin needle, pushes it through the chest wall, into the lung, tries to hit the tumor, pulls it out, gives it to me, smear it on a glass slide, and I look at it instantly under the microscope. And I say, you're in or you're out. Actually, I don't always do that. We have cytotechnologists who do that. I do it sometimes. Now, the radiologist is using the X-ray or the CT as a guide. So if they do this, and I look under the microscope and I say, I don't see anything, it's possible, in fact, it is, that they missed it. And I might say, go back and get me some more. Or I might say, this is dead tissue. Now, necrosis is more common in things like squamous cell carcinoma. And I might say, this is necrotic, go back in there and dig around a little bit more and get me some more. And you'll do that to the limit of the ability to reach the lesion and the limit of the patient to withstand the procedure. It's not a very dangerous procedure, but there are some reasons to stop. So that's how we look at it without a microscope right then and there next to the patient. We take the microscope with us. That's one way to do it. Another way is to go to surgery, open the chest wall, and take out the lesion. When they take out the lesion, there's very little chance of missing it, but the patient has to go through what they call a thoracotomy and have their chest opened, which is not a simple procedure. But that's another way to get tissue. There's no pathologist alive who said, give me less tissue. It's just not the way we work. We want more. More is more. Less is less. And when we have the microscope next to the patient, we can say, I know what this is, but I need you to give me a bigger piece so that I can send it to molecular. And it's when they don't send you enough that you get back the results that molecular didn't work.
I guess my question, and I'm assuming that maybe some folks watching might have the same question, how do you determine sort of which road to take, whether it's the cytology sort of path or
Okay.
Yeah.
Go to surgery. Well, you can't treat anyone with chemo or any other kind of drug without a tissue diagnosis, without cells. You can't just look at somebody and say, oh, you have lung cancer, I'm going to give you chemo. Can't do that. You have to obtain material from the patient. Now, if the patient has widespread disease, both lungs, brain, liver, multiple sites, that patient's not an operable candidate. Taking the patient to surgery isn't going to help them. So why take them to surgery? Stick a needle in there and get your answer. If the patient has a small lesion that's going to be removed anyway, then don't stick a needle in there first. Go and take it out. So it depends on the location and the size. Now you can have multiple lesions. If you have multiple lesions, you have to sample at least one of them. And if they're on both sides of the lung, you want to take a sample from both sides of the lung, because other things besides tumor can look like lesion. TB, fungus infections, different things like that. But we know from experience and follow-up that certain things look certain ways. Not to get too technical, but a semi-solid lesion on a CT scan is more likely to be lung cancer than a solid lesion is. So if all the lesions are solid and they haven't grown in a year, they're probably not cancer. So you kind of put together the X-ray picture and the interval between the X-rays to decide. It gets a little bit trickier when you go for screening and a very small lesion is found. A decision has to be made, what do I do with that lesion? Because some little tiny tumors never grow and never do anything. So you subject the patient to a surgery to remove something that maybe never would have done anything in the first place, but we don't know. We can look at it and we can look at characteristics of it and we can try to say what we think it would do, but we don't know 100%.
Yeah, I think that's a really great point, particularly when it comes to screening, because we also get a lot of calls from people who say, well, they found this 4 millimeter something, but now they want to watch weight and they're recommending I come back in 6
People
months.
don't like to hear that. Nobody wants to hear, you have something in your lung, please wait. I mean, nobody wants to hear that. I don't want to hear that. You want them to get it out.
Correct. But is it not the reality that a lot of us, especially as we get older, have these sort of anomalies, benign anomalies, that will show up on CT?
Yes. And it also depends on where you live and what you were exposed to and who you live with. If you live with somebody who has TB, you can get a lesion in your lung. If you go and decide to hike into San Joaquin Valley, you can get cryptococcus. All of these things can happen. And they look similar on a screening test, but they have gotten very good at refining screening tests, and they can really get a really good idea about what a lesion is. And if they say you have a 4 millimeter lesion, come back in 6 or 8 months, they don't say that lightly. They don't say that lightly. They're not that scared. And truthfully, not a whole lot is going to happen to you in 4 or 6 months, even if it is a tumor. So it doesn't feel good. Nobody wants to hear it, but patients should be reassured a little bit when someone says, oh, come back next year.
I agree. And patients should understand that this is evidence-based. These are evidence-based recommendations, right?
Absolutely. Nobody's making this stuff up day by day.
Yeah,
thousands
I agree.
and thousands and thousands of screening scans have been evaluated, and the tumors have been evaluated, and it's now the thing that people have a hard time with, I find, in science and medicine, especially now that we live with COVID. I often hear people say, well, they said last week that it wasn't going to mutate, and now it's mutating, and they said last week that this chemo worked, and now it doesn't work. The problem with science is that it's always moving. And you know the best thing at the moment, but 2 or 10 times moments away, it may be different. And I think that's hard for patients. It's not static.
Can we talk a little bit about, we've talked about types of tumors and what you're originally looking for. A, is it a malignancy? B, is it a lung malignancy? C, yes, it's a lung malignancy. What type of lung cancer is it? We've talked about staging and the pathological staging. Now let's jump into biomarkers and mutations, right? And I haven't been in this space as long as you. It's been since like 2003. And in 2003, even the very first biomarker that was identified and had an FDA approved therapy for it was EGFR. And that was in clinical trials back then. And we've come leaps and bounds from there. Not enough.
You're talking about something that happened where 3 papers almost simultaneously came out that identified a mutation in the cell that was likely to respond to a certain substance. Prior to that, nobody had any idea what drove lung cancer. It was cigarette smoke in some way, but they had no idea what. And once EGFR was located, identified, and targeted, people started looking like crazy, every which way they knew how to look, until they found out more and more and more. Now, it is very unusual today to have a lung cancer without a mutation. The thing about the mutations is that they have to be driver mutations. Some mutations just exist, and some mutations cause the tumor to go. And once you find the mutation that drives the tumor, you have to match it with the drug that targets just that mutation. And right now, I would say upwards of 85% of tumors, we know what drives them. We don't have medicine for all of them, but we know what drives them. And we know that once we give them medicine for those mutations, the tumor wants to stick around. It wants to change. It doesn't want to go away. So sometimes they develop a resistance to the medicine that they're given. And that resistance can also be measured by another mutation. Now, you mentioned EGFR, and the most common resistance in EGFR is T790M, but there's medicine for that too. And as each year goes by, more and more drugs are put into use to target those mutations. Now, it would be beyond the scope of our program for me to list what they all are and to list the drugs that match them. Some places, for example, like Memorial Sloan Kettering, analyze about 500 different mutations. Other places analyze the 50 most common. I'm not going to tell you that one place is better than another, but I am going to say that if you have a small panel of perhaps 50 genes and it's negative, go get another one, because there's something in there. And chances are there's medicine for it. Now, most of the tumors are going to be in that 50 panel. But if yours isn't, go and get another look. Now, even if a mutation is infrequent, like perhaps it's only 2% of the population, when you think of the number of people with lung cancer, that 2% is thousands of people.
So in your opinion, and I think I'm hearing it loud and clear, I just want to make sure everyone's hearing it loud and clear, how important is this biomarker testing to the patient prior to starting their first line of therapy? Because a lot of patients are terrified, like when my doctor wants to wait for these results to come back, it could take 2 to 3 weeks. I want to start treatment now.
Okay. Well, the first thing is 2 or 3 weeks is not going to make a difference. And if you've had surgery, you need 2 or 3 weeks to get better anyway before you can get drugs. If there's a delay in getting your biomarker status, chemo's never wrong. Patients with certain biomarkers do better on chemo than patients without that mutation. Chemo's never wrong. So if you're desperate and you can't wait for whatever reason, take the chemo, add the targeted therapy with the chemo or drop the chemo. But it's never wrong to give somebody chemo. It might not be the very best. It's like, if I can't get premium gasoline, am I going to not go anywhere, or will I take regular? Then you could say, okay, I got the biomarker back. I'm going to do better on this targeted therapy. Drop the chemo or add it. That's a decision for an oncologist to make. I don't want to make that decision. But I don't want people to realize that time is not that much of an essence. There are situations where you have to move quickly, but those are situations where usually they have to do with where the tumor is located. If a tumor is located in a place that's going to compromise a vital organ, you have to do something. But the lung's pretty big. It's not going to really do too much in there in 2 or 3 weeks.
Yeah.
But that's not how it feels when you're the patient.
When you're a patient, for sure.
It doesn't feel
but
like that.
Yeah, I so appreciate you sharing that, because I think it provides some solace to those who may be waiting right now, who are watching.
Of course,
and thinking,
they're waiting and watching and scared.
Yeah.
And I say to my trainees, every time you pick up one of these slides, there's somebody down the hall waiting, holding their breath, waiting for you to tell them what's on that slide. It's horrible to be a patient. I admire the patients. It's horrible to be a patient, but some things should offer some solace. You can mail a tumor to a testing lab. Nothing's going to happen if you wait 2 or 3 weeks. If you take chemo, it's not wrong. You haven't destroyed your opportunities for a different drug. You may not be able to get into a certain trial if you've had chemo first, but it's not going to hurt you. Other than the normal side effects that you'll get from chemo. You're not hurting yourself by using chemo.
Yeah, and the normal side effects from chemo, I think, and again, for those of you who are veterans and those of you who are new, we've talked about this a lot before. There are so many supportive drugs and therapies to sort of counteract the side effects of chemotherapy.
Such good stuff.
Yeah, I'm going to plug the palliative therapy and palliative care folks out there who are really working on team, patient, whoever, to help with some of the side effects of treatment. And it's so important.
Good oncologists can really manipulate those drugs. They have a lot of off-label use for drugs, for example, that will stop nausea.
Yeah, I agree. And I think I'm going to give a sort of a plug in one of the things that we at GO2 believe in wholeheartedly. And I touched on it a little bit before. The expectation, particularly in some of the more rural settings, for all of this to be set up and in place, and for a pathologist to be at the bedside at the time of biopsy, that is not realistic. But what is realistic is the opportunity for second opinions at places such as Mount Sinai, or someplace close.
I get second opinions. People ask every day for second opinion, and we do not look upon that as an insult or a distrust. We're happy to give a second opinion. I do it every day. Mount Sinai has a big consultation service of many, many oncologists. And something that the patients may not know about, or they might, is digital pathology. The technology is getting so good now, not so much in cytology, but in surgical pathology, when things come out of the OR, that you can shoot an image from the OR and the microscope to somebody across the country and get a second opinion right then and there. So digital pathology is growing enormously. And that allows, as you said, people in rural areas to maybe get a second opinion on the spot.
So I want to pause before we move into, I want to say some final thoughts about the biomarker testing, looking for mutations and fusions and proteins and all of these other things that might be floating around, and your role in identifying those and working with the healthcare providers, the medical oncologists and the like, to come up with appropriate therapies. Before we jump into immunotherapy, there is a question online, and it says a patient that had a pneumonectomy, after the lung was removed, the pathology report said there was lymphovascular invasion and perineural invasion. Once the lung is removed, is this still a concern?
Yes. First of all, a pneumonectomy is a big procedure, and it's not done lightly. Almost every single lung cancer has lymphovascular invasion. The anatomy of the lung is such that the walls that make up the air spaces are so thin that they only exist of one blood vessel. So it's not realistic to assume that there's not lymphovascular invasion, even if you have a small tumor that's completely removed. And once you have lymphovascular invasion, it means the tumor has reached into your bloodstream and doesn't mean it will, but it can spread. And so what that means is that you want follow-up on the patient. You want the patient to come back and be scanned or be tested as follow-up. And even if you don't have lymphovascular invasion, you want that anyway. Perineural invasion means that it's grown around the nerve, and when those kinds of things happen, they can be painful. And it's a measure of the spread. But just because you have lymphovascular invasion doesn't mean it's going to spread. It means it's capable of spreading.
Great. So now let's jump into PD-L1, talk a little bit about that and whether or not all of this testing is done the same. Is it done differently? Is it one test searching for all of these biomarkers, including PD-L1, or are they separate things, and why is PD-L1?
That's a big, big field. PD-L1 testing is a stain. It happens to be an immunoperoxidase stain. You stain a piece of tissue, and you see if the tissue cells take up the stain. And if they do take up the stain, you can see a color under a microscope. And where in the cell the color is located is important. And how much of the cells present take up the color is important. So different companies make the stain, and different companies ask you to evaluate the stain in different ways. Some companies will say, when you use this stain, we want you to count 100. When you use this stain, we want it to be membranous. So that gets to be problematic. There's more than one. It's like if you dye your hair. There's more than one hair dye out there. Which one is going to work for you, right? You got to follow the instructions. So the best way to approach that is for the laboratory where you work, like at Sinai, we use one kind of stain and we have one kind of protocol. And we know that that matches up well with the patients responding to the therapy. And in fact, there are certain drugs that require that study to be done. And certain drugs require 1% positivity, others require other percentages of positivity to release that drug. I think that's going away, and I think the drugs are going to become available without the staining because it's very, very subjective. Some part of this tumor may stain, another part may not. It may stain and not respond. So the answer to the question is, when it comes to PD-L1, there are different stains out there made by different companies, and you have to follow the guidelines and be consistent. And when you stain for PDL, that's all you're staining for. It's one stain, one marker. There are other markers you can do, but PDL does not cover anything but PDL.
You made a point earlier about how this is a fluid environment and science is continually moving. And when immunotherapies first came out, guidelines were X, Y, and Z about who did and who didn't qualify for this type of therapy. And they've changed, right?
Mm-hmm. And they're going to change again.
And they're going to change again. And I think that's one of the frustrating things for the patient and caregiver communities, because they're like, oh, it's not just, oh, we discovered this and now this is it. No, the good news is something better is going to come along.
Yeah, but it's frustrating for us too, because we have to learn it. And then after we learn it, we have to teach it. It's not like it was 20 years ago, where there were like 5 different medicines, and patients deserve the best. It's not always possible for everyone to give the patient the best because they don't always have it themselves. It's not easy, and they deserve to have every advantage that exists.
I will plug again GO2 and our helpline, and I know we've been flashing it up here on the screen for everyone to see, but we do have an incredibly brilliant staff answering our helpline and being able to guide you.
And you also have patients who have been through the experience.
Yes, and we have a lung match team who's able to help you. Speaking of, the topic is pathology. Quite often, even the pathology reports that are sent to the patient, and that's not always done, but when it is, it's like reading a different language.
The number that you're given, your pathology record number. If I look at another hospital's pathology record and they say 22-175, I know that May of 2022, they've only seen 175 specimens. If it says 22-34,000, I know they've seen 34,000 specimens. So that'll give you an idea right there about what kind of lab you're looking at. But nobody knows that.
I just want to take some time for any final thoughts that you have, anything that you would like to share with the community that maybe we didn't touch on before we do some housekeeping and close up.
You can actually call the pathologist up who wrote your report and say, can you explain this to me? That happens all the time, and they will. And it's a tough journey. I think things are better now than they have ever been for the patients.
Again, a huge, huge thank you to Dr. Zakowski, to Penn Media, everyone watching tonight, our go-to team across the board for all of the work that you put in tirelessly for this community. Thank you, thank you, thank you. Our sponsors, of course, tonight's event was sponsored by Janssen Oncology, as well as supported by Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Merck, Mirati, Novartis, Regeneron Sanofi, and Takeda. And if that list doesn't tell you how important everybody thinks this programming is, I don't know what does. So thank you all for joining. We hope to see you in June. Have a great rest of your evening.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.